Now we will be talking about treatment of asthma exacerbation in case of primary care center. So first of all, you need to make it clear whether it is asthma or not, isn't it? So you need to look at the clinical features, you need to look at the history, and if it is old patient, then you need to rule out whether it is heart failure or not, and you have to rule out other different causes of acute breathlessness such as pulmonary embolism or upper airway dysfunction. So these things need to be kept in mind while assessing that, and after that you need to look out for the risk factor of poor outcome, isn't it? Suppose if there is early exacerbation in a year and he is not using ICS, and he is like using more than 12 canisters of Saba per year, so all those risk factors you need to assess, and you also need to assess the comorbidities like obesity, anxiety, depression, and other things that we have already discussed previously. So immediately you have to be judgmental to note all those things, and then now you need to classify the category of patients into mild, moderate, severe, and fatal. So let us see what are the criteria to be kept in fatal or dire emergency cases. Suppose if the patient is drowsy, unconscious, and there is absent chest sound, then they are kept into very severe category of patient. And while talking about mild, moderate, and severe, if the respiratory rate is increased, however, if it is less than 30, then it is mild or moderate. However, if the respiratory rate is more than 30, then it is severe form. If the heart rate is more than 120, then it is severe. If the SpO2 is less than 90%, then it is severe. However, if it is 90 to 95, then it is moderate, and greater than 95, it is mild. And PEF, if it is less than 50% than the expected, then it is severe. If there is respiratory distress signs such as use of accessory muscles, chest increasing, nasal flaring, then it is kept under severe category. And if one breath, if he is able to complete the sentence, then he is mild or moderate. But if he is just only able to speak one or two words, then it is kept into severe category. So till now what we have done, we have assessed whether it is asthma or not. We have briefly checked out its risk factor for poor outcome, and then now we have categorized the patient into mild, moderate, severe, and dire emergency. So in case of fatal or very severe cases, what we do is that we give reliever medication, that is SABA of course, and ipratropium bromide inhalation along with oxygen therapy, and we give systemic corticosteroids, that can be hydrocortisone, and then we refer them to the higher upper center. So if it is severe, then we again do the same as protocol as that of the fatal cases. However, if it is mild and moderate, then we need to manage them by giving reliever medication 10 puffs at 60 to 60 second interval 1 puff. So we can give that up to 4 to 10 times, and at the interval of 20 minutes for 1 hour. Then we need to reassess them after 1 hour and note whether the symptom has subsided or it is worsening or not. And meanwhile, we also give prednisolone. Prednisolone we can give 40 to 50 mg for adult dose and 1 to 2 microgram per kg for children dose. And we also give oxygen therapy of course. So suppose let's say the situation is not improving, then we again refer. However, if the situation is improving, then what we can do is that we can now give reliever dose at interval of 30 minutes each, and again if the symptom is improving, then we can give reliever at the time interval of 4 to 6 hourly, and we can give hydrocortisone at interval of 6 to 8 hourly. So if the patient is improving, and we need to reassess them periodically. And after that, if the symptom is now subsided and patient does not require reliever medication, then we need to prepare for discharge. However, before discharging, we need to keep certain things in mind. One, that in 24-hour time interval, he does not require any kind of reliever therapy. And the second being that the oxygen is in the required amount. Suppose for adult it is 93 to 95%. However, in pediatric age group it is 94 to 98%. And if during the course of treatment, if the oxygen therapy is meet to that level, then we can think of discharge. And while doing discharge, what are the things to be kept in mind? First and foremost being the revisit or reappointment for after a week, that is after 1 week. isn't it? And another thing is that you need to have a written action plan in case of any severe exacerbation in immediate future. And another being is that you need to monitor whether the drug is adequate or not. You need to check his inhalation technique and whether he is doing it correctly or not. If he is doing wrong, then you need to correct him and again reassure him. And then this way the treatment goes in. So after 1 week you call him back and then you note whether the therapy ongoing is adequate for him or not. If it is not, then you go for a step up approach. So this is the way how it works at primary care center. So briefly talking about in advanced care center or something like that, suppose a patient comes to you, then what would you do? So you confirm the asthma case, you confirm it, and then you assess the risk factor, and then you label the patient as this, that, and that. That is mild, moderate, severe, or near a very severe case. And then what you do is that for mild and moderate case, you give reliever medication and you give prednisolone, that is in oral form. If it is a kind of severe, then you need to go for, and if the symptom does not improve, then you need to go for IV hydrocortisone can be given in case if in that case, and dose being 5 mg per kg for hydrocortisone. And again, if the symptom does not improve, then you need to go for and meanwhile at the same time ipratropium bromide is given, that is 250 mg 68 hourly. And then you keep on giving, if the symptom does not improve, then you can give IV theophylline, and then you give magnesium sulfate, dose being 50 mg per kg if the symptom does not improve again. And if during this line of treatment also if the symptom does not subside, then you need to think of mechanical ventilation. Meanwhile, you also need to exclude other things such as heart failure, whether there is pneumonia or not, and you need to exclude like if there is pneumothorax or not. So in these cases X-ray and different lab investigations play crucial role. So once again, the thing to be considered is that you need to confirm whether it is asthma or not, and you need to quickly assess the risk factor for poor prognosis, and then you need to label the patient into mild, moderate, severe and fatal. And after labeling the patient into the category, you do manage according to the category. Suppose if it is severe and fatal, then you need to do immediate referral, and during that time you give reliever medication and ipratropium bromide along with oxygen therapy, and you give systemic corticosteroids such as hydrocortisone. And in case of mild and moderate, you give puff of reliever therapy, up to 10 puffs you can give at 20 minutes each for 1 hour. And meanwhile you also give oxygen therapy and prednisolone, or you can give hydrocortisone. If the symptom is worsening, then you can refer, or you can go for other measures like IV hydrocortisone, and then you go for ipratropium bromide of course, and then you give IV theophylline, or you can give slow IV magnesium sulfate. And if all those things does not work properly, then you need to think of mechanical ventilation, and you need to think of other diagnostic features like pneumothorax, heart failure, pulmonary embolisms, and other investigations should be carried out. And suppose if the person has now being relieved, then you can have higher doses of in case of pediatric age group, if the symptom is relieved, suppose it is first severe exacerbation and the symptom has relieved, then you can give the maintenance dose therapy of ICS for 2 to 3 months, and after subsidence of symptom you can stop it. So these are things you need to keep in mind. The main thing always being is that you need to assess, adjust, and you need to recheck the treatment strategies. So you need to assess the symptoms and the status of the asthmatic patient. You need to check for the risk factor for prognosis, and then you go for the comorbidities, and then you go for the treatment, how it is going on, whether he is compliant or not, whether he is adherent to the therapy or not, whether he is using the right technique or not, whether he is using adequate dose or not, whether you may need to step up the therapy or step down the therapy. So all those things you need to keep in mind and do accordingly. So I hope this much for today. See you next time. Thank you.